Thank you so much for that kind invitation and that kind introduction. It is great to have the opportunity to speak as part of this conference, even though it's virtual. I was hoping to be in India and be able to present live to you, but this is going to work with all the chaos that's going on in the world. I'm trying to share my screen, but the host has disabled my ability to share screen. So would you be able to allow me to share my screen, please? All right, I'm just going to keep talking because I don't know if this is going to work, and we only have 40 minutes. So I'm going to start talking, and we'll catch up with slides as we get through. But thanks to the Keher Institute for giving me the opportunity to speak with you this morning in India. It's late in the night here in the US, but hopefully I can share with you my passion for cardiovascular and pulmonary physiotherapy, especially in this area of hypertension, which is so prevalent in the United States, in India, and in the world. So to begin, let me see if I can share now. Okay, perfect. It is working now. So let's get started. All right. So looks like perfect. I'm hoping you can see my screen, and let's get started.
Yes, we can see you.
So really what I'd like to talk about in the next 35 minutes is start by talking about a global definition of hypertension, then move into some new classification systems of hypertension that we use here in the United States, going very quickly over the categories of hypertension or the types, three major types, really quickly reviewing pathophysiology of hypertension, a quick review on orthostatic hypotension, and then really spending some time on evidence-based lifestyle interventions with a summary and conclusion. So I've got quite a bit on my agenda for 35 minutes, but I think we'll be able to get through this really quickly. All right, so really, as you all know, hypertension is really defined as a chronic elevation in the arterial blood pressure. And most of the world defines hypertension as a blood pressure greater than 140/90. Now, in the United States, we like to be a little different. So in 2017, in November 2017, the American Heart Association changed the guidelines. So we always, in the United States, defined hypertension as a blood pressure greater than 140/90. But in 2017, the American Heart Association changed the guidelines to defining hypertension as a chronic elevation in the blood pressure greater than 130/80. So if we look at the new guidelines, then we really define normal blood pressure today as a blood pressure less than 120/80. So if your blood pressure is less than 120/80, we say that you now have normal blood pressure. If your blood pressure is between 120 and 129 systolic and under 80 diastolic, we now say that you have elevated blood pressure. And if you have elevated blood pressure, the guidelines recommend that really we recommend to individuals lifestyle changes with a reassessment of the blood pressure in 3 to 6 months. Well, lifestyle changes that we're going to come to really quickly in the presentation with a reassessment of the blood pressure in 3 to 6 months. Now, if somebody's blood pressure is between 130 or 139 systolic, or is important, or 80 to 89 diastolic, we now say you are classified as being in stage 1 hypertension, stage 1 hypertension. And if you are in stage 1 hypertension, the next thing that we're asking clinicians to do based on the guidelines is to look at the individual's 10-year risk for possibly having heart disease or stroke. So we call it the ASCVD risk assessment. That's the which I'm going to come to really in the next slide. So we look at what is the patient's risk for having a cardiovascular event or stroke in the next 10 years. So to get to that, you can find this risk assessment free online. I gave you the QR code. So if you have a smartphone, you can just shine your camera. You can take your camera, you can shine your camera on the QR code, and it'll pop up the website right away to give you the risk estimator. If you don't have a smartphone, maybe you have a flip phone, that's totally cool. You can just Google it and put atherosclerotic cardiovascular disease risk estimator, and it will basically give you this website. So if I had to go in and basically show you the risk estimator, what this risk estimator is doing is that you put in a bunch of variables. You put in your age, you put in your gender, you put in your race, you put in your blood pressure, you put in your cholesterol levels, HDL, LDL, your diabetes, your smoking history, all of that stuff, and it spits out a number, right? It spits out your risk for having a cardiovascular event in the next 10 years. What is your risk for having a cardiovascular event in the next 10 years? So if your risk for having a cardiovascular event is less than 10%, if you are less than 10% risk of having a cardiovascular event in the next 10 years, there, along with a blood pressure of 130 to 139 systolic or 80 to 89 diastolic, we now recommend lifestyle changes for that individual with a reassessment of the blood pressure in 3 to 6 months. However, if your risk for having a cardiovascular event is greater than 10%, along with the blood pressures of 130 to 139 or 80 to 89 diastolic, we now recommend one antihypertensive medication along with lifestyle changes with monthly follow-ups to make sure that the blood pressure is really under 130, preferably under 120 over 80, but at least under 130 to really make sure that the blood pressure is managed. If the individual's blood pressure is greater than 140 over 90, 140 or 90 diastolic, we now say the individual is in stage 2 hypertension. And if the individual is in stage 2 hypertension, we recommend lifestyle changes along with two antihypertensive medications along with lifestyle changes. So those are the new guidelines that we follow here in the United States based on what is recommended by the American Heart Association. The World Health Organization, and you in India follow World Health Organization guidelines, still follows the guidelines of 140 over 90. So it really just depends, but if you have an individual who is really at risk for heart disease, it may not be a bad idea to be a little more aggressive and to really look at the recommendations as stated by the American Heart Association. So the question that begs consideration is that for decades, we always thought about the blood pressure of 140 over 90 as a blood pressure that we call as hypertensive. We always believe that if somebody's blood pressure is greater than 140 over 90, they're hypertensive. The question is, why did the guidelines change on November 13th, 2007? Why did the guidelines change? And the guidelines changed because of a very important landmark paper published in the New England Journal of Medicine called the SPRINT trial. SPRINT stands for Systolic Pressure Intervention Trial, Systolic Pressure Intervention Trial. And the SPRINT trial that was published in the New England Journal of Medicine asked a very simple question. And the question that this research study asked is, we always treated patients with medications if their systolic pressure was greater than 140, right? And we treated them to keep their systolic pressures under 140. That's how we've always done it. But what the SPRINT trial did is that it looked to see, what if I am more aggressive with the medication? And what if I try to keep the systolic blood pressure under 120? If I keep the systolic blood pressure under 120, would that yield better outcomes as opposed to being less aggressive and keeping the systolic blood pressure under 140? So would there be added benefit by being more aggressive with medications to keep the systolic blood pressure under 120 instead of under 140. So they did a very large, multi-centered, randomized control trial, right? They looked at centers all over the United States. And they included over 9,000 patients that were not diabetic. They were not diabetic, greater than 50 years of age, who were at high risk for cardiovascular events. So they had a cardiovascular risk estimate of greater than 10%. So based on your 10-year risk of having a stroke or some type of cardiovascular event was greater than 10% in 10 years. And they did not have a prior stroke. So if you went to the doctor's office all over, anywhere, different cities in the United States, you were not diabetic, you were over 50 years of age, you had greater than 10% risk of having a cardiovascular event, and you did not have a stroke, they said, you are eligible for the study. Would you like to sign up? And if you signed the informed consent, what they did is that they measured blood pressure. And the way they measured blood pressure is they took the patient into a quiet room. They put an automatic cuff on the patient, and they kept that patient in an automatic room for 5 minutes. No smoking, no coffee, no one in the room. And after 5 minutes, the automatic cuff took a blood pressure reading. It waited a minute, it took a second blood pressure reading. It waited a minute, it took a third blood pressure reading. And the average of the three readings is the blood pressure they used to treat. So once they got that blood pressure, they randomized patients into a more aggressive group where they gave the patient more medications to keep their systolic blood pressures under 120, or there was a less aggressive group where they kept the systolic blood pressures under 140 in the range of 135 to 139. They had the patient come in every month for 3 months to make sure that their systolic blood pressures were in the range they wanted them to be. And then they followed them up every 3 months thereafter to make sure that their blood pressure was really under control. They planned to follow these patients for 5 years. But when you're doing such a large study, you have to send your data into the Data Monitoring Center in Washington, D.C. And the Data Monitoring Center was tracking the data, and they found that there was really marked superiority in the intensive group compared to the standard of care group. And because there was so much of superiority in the outcome variables, that they stopped the trial early after 3 years. So what did they look at in terms of outcome variables? What they looked at is they looked at a composite endpoint for any event that occurred for the first time. It could be a myocardial infarction, it could be chest pain, any in the spectrum of acute coronary syndrome events, coming in for heart failure, coming in for a stroke. Any of those were counted as a composite variable. So we're looking at the number of events that occur. What was the number of events in those that were more aggressively treated for their blood pressure as opposed to those that were less aggressively treated? And secondarily, they looked at all-cause mortality. They found 25% fewer events in those that were more aggressively treated compared to those that were less aggressively treated. 5.2% of those in the more aggressive group had an event within 3 years follow-up. 6.8% of people in the less aggressive group had an event. There was a statistically significant difference between the two groups, p markedly less than 0.001. There was a 27% reduction in death in all-cause mortality. 3.3% of people in the less aggressive group, in the more aggressive group, died. 4.5% of people in the less aggressive group died. There was a significant difference, a p-value 3. Yes, the more aggressive group did have some more syncope, electrolyte abnormalities, some acute kidney injury, but the benefits of reducing events and reducing mortality far outweighed these negative effects that we saw in people that were more aggressively treated. So as I read this article, what really came to my mind? Really, what came to my mind as I read this article? And if we had more time, I would give you the opportunity to kind of get into a breakout room and kind of think about it, but we don't have time for that. So I'm just going to tell you what really came to my mind as I read this article. And the first thing that came to my mind is, really, should somebody who is 75 years of age or 80 years of age really have a blood pressure, a systolic blood pressure of 120? I mean, really, should somebody who's 75 or 80 years old really have a systolic blood pressure under 120? Now, when you look at the sprint population, right, 28% of the sprint population, 28% of the sprint population was greater than 65 years of age. But if you look at that 28% that was greater than 65 years of age, those individuals were not the average 75-year-olds or 70-year-olds that you see in physical therapist practice. These individuals were driving to the doctor's office every month. They were going to dinner. They were playing with their grandchildren. They were not somebody who is in bed with 50,000 problems, right, with multiple comorbidities. So what is that trying to say? What that's trying to say is, if you have an older individual who does not have many comorbidities, who does not have diabetes, who is active in the community, and if that person wants to have better quality of life, reduce their risk for having events, reduce their risk for dying, then being more aggressive with their blood pressure may not be a bad idea. But if you have somebody with multiple comorbidities, who has diabetes, who has all these other problems, then it may not be appropriate to be very aggressive with their blood pressure management. So that's the first thing that came to my mind. The second thing to appreciate is that in the sprint trial, they did not use people with diabetes. They did not use people with diabetes. Why? Why did they not use people with diabetes? Because if you have somebody with diabetes who really has who is on anti-glycemic medications that drop their sugar, and in addition, you give them medications to drop their blood pressure in a more aggressive way, you can really make them symptomatic. Because you're dropping their sugars and you're dropping their blood pressures, you can make them really symptomatic. They tried that in an earlier trial called the Accord trial. And in the Accord trial that was published earlier, they did not show benefit because they were dropping blood pressures and sugars at the same time. So really, the guidelines for what we define as hypertension is a blood pressure greater than 140/90 in people who are diabetic. In people who are diabetic, we use the American Diabetes Association guidelines, which define hypertension as a blood pressure greater than 140/90 and not 130/80. The next thing that came to my mind is, really, whenever they stop a trial early, in my mind, I'm thinking you stop a trial either at the best point in the trial or at the worst point in the trial. In this case, they stopped the trial at the best point. So we really have no idea what it would be if they carried on the trial for 5 years, right? So whenever, you got to keep that at the back of your mind, because whenever they stop the trial, they don't always stop the trial, through its full course. So we wouldn't ever know what the results are because the trial was stopped early. So those were some considerations I thought about that I think is meaningful for us to think about as we review the data and see how this data transforms guidelines. All right, so there's a growing body of evidence, really, in showing now how blood pressure control can really help with dementia, it can help with cognitive decline and dementia. And in 2019, in January 2019, in JAMA, in the Journal of American Medical Association, they have two very important trials, which we call the Sprint Mind trial. And in the Sprint Mind trial, they took a subset of people, and they found that in the subset of people, there was lower rates of mild cognitive impairments and lower rates of dementia in people that were more aggressively managed for their blood pressure compared to those that were less aggressively managed. This is huge because dementia is becoming a big problem in the elderly population, right? And if we can get people to control their blood pressures, we can really help offset or reduce these incidents of cognitive impairments and dementia by keeping their blood pressure under control. In the second Sprint Mind trial, which was published in the same edition of JAMA, they also looked at biomarkers in the brain. And the biomarker in the brain is that they looked at is something we call white matter hyperintensity on MRI imaging. They looked at white matter hyperintensity on MRI imaging. White matter hyperintensity is really imaging of small vessels in the brain. It's imaging of small vessels in the brain that indicates vascular injury in the brain, And they found that those that were more aggressively treated had lower levels of white matter hyperintensity on this FLAIR imaging on MRI. It basically slows down vascular injury, which is really, really important information to understand that just keeping blood pressure under control can now change biomarkers in the brain. So it's so important if you're working in an outpatient clinic, if you're working in home health, really take people's blood pressure and really urge them to get their blood pressure under control, not only to really reduce cardiovascular events, but now to help with cognitive decline and reductions in dementia that we may see in elderly patients and clients. So when we think about the categories of hypertension, essential hypertension is really hypertension that occurs in the absence of disease. No pathology, the patient is just hypertensive for no known cause, really because something is vasoconstricting the vessel. Non-essential is caused because of some pathology like stenosis of the renal vasculature or aldosterone issues. Resistant hypertension is when the patient has a blood pressure greater than 140/90, despite being on 3 antihypertensive medications, one of which is a diuretic. And for these individuals, if somebody that you see is resistant, number one, very important to see, do they have white coat syndrome? And to rule out white coat syndrome, it may be useful for them to keep a blood pressure log, buy an automatic cuff, take their blood pressures throughout the day, and see how that compares to the blood pressure that you're taking with them, because it may be higher just because you're there. The other thing is, are they compliant with their medications, right? Are they compliant? And we know so many patients are not compliant with their medications because they're on so many medications that reduces compliance. So monitoring compliance and adherence to medications becomes really important when you see a patient who's on multiple medications and their blood pressures are still high. You know, just giving people medications doesn't show value in care. But if we can ensure that the patient is compliant with their medications, it now shows value. And it's really all about value that makes what we're doing really, really important. Okay, so moving on. I think you already know the pathophysiology of the renin-angiotensin system, where renin is released when sympathetic stimulation is high, or your blood pressure drops. And that basically causes you to develop angiotensin 1 to angiotensin 2. And that basically, the angiotensin 2 that you make causes vasoconstriction, and it also causes sodium and water retention. Now, you can stop this pathway through multiple medications. You can give them ACE inhibitors. You can give them mineralocorticoid receptor antagonists that block aldosterone. You can give them diuretics. You can give them vasodilators. You can give them beta blockers. And all of these medications, they really lead to orthostatic hypotension. Orthostatic hypotension is a drop in the blood pressure with transitional movements. And we really see this drop of 20 systolic, 10 diastolic. And the best way to assess orthostatic is really to go directly from supine to standing. But so often, especially in elderly people, especially in people in acute care that have not really been able to get out of bed, we need to get them into sitting at the edge of the bed and then standing. But it's important to appreciate that when you get people seated before standing, there is a smaller depressor response in the blood pressure. So the blood pressure drops less when you go from supine to seated to standing compared to the drop in blood pressure if you go directly from supine to standing. So it's important to kind of keep that at the back of your mind if you do have the patient sit at the edge of the bed and then go into standing. Now, one of the papers that I really like with respect to orthostatic hypotension is a paper that was published. It's a review paper that was published by Sutter and Matson in the Journal of Acute Care Physical Therapy in January 2020. And what I really like about this paper is that, number one, it talks about the different classifications of hypotension. And of course, if we see that drop in 20 of systolic, a drop in 10 of diastolic, then we basically say that that is orthostatic hypotension. But it's also important to appreciate that somebody who has supine hypertension with systolic blood pressures greater than 160, who now drops systolic blood pressures greater than 30, with transitional movements, they are considered orthostatic as well. Very important to appreciate that most people with orthostatic hypotension have the reverse problem of being hypertensive in supine. They're hypertensive in supine. That is why it is really important when we prescribe medications to people, we always prescribe medications based on the upright blood pressure. It's really never based on the supine blood pressure. It's always based on the upright blood pressure, right? Now, if you look at an acute care, physicians are coming in the hospital, physicians are coming and they're changing people's medications by the minute, by the hour. And they're not getting these people upright. They're basically changing medications based on the supine blood pressure. These patients are not getting out of bed till the physical therapist walks in. So when you come in, you're much more likely to see the patient orthostatic because they're prescribing medication based on the supine blood pressure that is falsely elevated because the patient is in supine. So it's kind of important to keep that at the back of your mind when you are treating these patients. We have two major types of orthostasis. Classic orthostasis is this sustained drop in the blood pressure, but that initial orthostatic hypotension is what we usually see in very young adults, young people, where they have this abrupt drop in their blood pressure, greater than 40 systolic, 20 diastolic, which basically reverses itself within the minute. They drop, and if they can hold themselves upright, they just have that problem with basically that reflex mechanism is lost. Their blood pressure drops. If they can hold themselves up, it takes within the minute, it goes back. We have neurological issues and non-neurogenic causes for orthostasis, and you can see this in the slide. I'm not going to get into it, but I think you probably already know that. One important point, so many patients don't realize that if they don't get their blood pressure checked and managed, they're going to land up in heart failure. You know, I've written a guideline paper on the physical therapy guideline for management of patients with heart failure. And it's so important to understand that we need to manage people's blood pressure to really make sure that they don't land up in heart failure. So let's talk about some lifestyle changes. Weight loss, greater than 10% body weight is so important. So if somebody is 100 kilograms and you get them down to 90 kilograms, it can really make a difference in reducing their blood pressure. Really important to also think about diet. The DASH diet is what we recommend, which is the dietary approaches to stop hypertension. And you can go into Google and resources to find really the specifics on the DASH diet. Sodium restriction is important, preferably less than 1,000 milligrams per day. But if somebody's sodium intake is really high, starting off with less than 1,500 milligrams a day, but at least 1,000 milligram reduction in most adults is useful. And then alcohol consumption. We don't recommend no alcohol at all. For men, it's less than 2. For women, it's less than 1. Why? Because of something called the J curve. And in the J curve, you see that the hazard ratio for all-cause mortality is higher with no drinks as opposed to 1 drink a day, 7 drinks a week. So your hazard ratio for all-cause mortality, your risk for dying is greater if you don't drink at all compared to if you drink 1 drink a day, 7 drinks a week. And then, of course, as you drink more, your risk for mortality increases. So because of this J curve, we recommend no more than 2 for men and 1 for women. The World Health Organization gives us a really important tool called the Health Improvement Card. If you're not familiar with this, you can look at the QR code, but it gives us this really important thing that gives us this red, yellow, and green zones that really allow the patient to see where they are in terms of risk factors and then create an action plan and a commitment to change certain risk factors. So this is free online. I gave you the QR code, but it's a valuable tool that people can use to really improve their lifestyle. Last 2 slides, exercise is so beneficial. And exercise, moderate intensity exercise, 3 to 4 times a week, 40 minutes a session, really helps these people. And what exercise does is that it reduces the sympathetic tone. That's how it works. And it also improves the integrity of the lining of the blood vessel, what we call the endothelium. So it keeps the endothelium healthier as well as it reduces sympathetic tone. So those are really the 2 main benefits of exercise at moderate intensity. I like this slide. You can screenshot it if you want, but this is a nice slide that really shows us what it is to exercise with light intensity, moderate intensity, vigorous intensity, based on MET levels, based on RPE scores, based on percentage of heart rate max. I think it's a really nice slide that helps us dose exercise at different intensities based on different parameters that we may be using. And finally, I think I really like this article on dance therapy, where they looked at, Concessio and colleagues looked at 4 studies on moderate intensity dance therapy, and they showed that moderate intensity dance therapy about 2 to 3 times a week can reduce blood pressure levels, it can improve quality of life, and it can improve exercise capacity. Why do I say this? Because if you have a sibling, or if you have a friend or a patient who does not want to go to the gym and do 3 sets of 10, but that individual likes to dance, dance therapy can improve quality of life, it can improve 6-minute walk distance, and it can reduce blood pressure. And if you add a cocktail, 1 drink a day, not an entire half a bottle of Johnny Walker, then life is good, right? So you add a cocktail to your dance, and that really makes life meaningful. So in summary, I hope I've been able to review the new guidelines for hypertension, some information on the pathophysiology in orthostatic hypertension, and the importance of risk factor modification in the contemporary management of patients with hypertension. Thanks so much for giving me your time. I appreciate your interest in attending this talk. Thanks to the Cohere Institute. All the best, and thank you again.